Is my exclusive group of patients at Great Ormond Street and the Institute of Urology. There's a few differences in operating on children, not least of which that you have to satisfy not only the patient, but the patient's parents, the grandparents, of which there are often 4, and various associated siblings, hangers-on, family, not to mention the nurses who seem very defensive about the patients as well. So the level of hysteria is risen in treating patients. But nonetheless, the physiology is the same. So what we're going to do is to go through now the kind of things that we can do to children, the kind of things that I do laparoscopically in my pediatric urology patients, and then we'll talk about a few areas of development, and then later on, because we don't unfortunately have a patient for laparoscopic nephrectomy, I'm going to show you some videos of the retroperitoneal and the transperitoneal approach, which I prepared before. And then we're going to do a small case, but the sort of case which most of you should try and start off with is a laparoscopic varicoccelectomy, which unfortunately is the only case that we have to do. Then tomorrow we're going to go maximally invasive, and we're going to do an extra reconstruction, but I'll tell you more about that later. So, the history of laparoscopy, you've probably heard already, it was first done in 1901. And in fact, I think several surgeons must have been tempted to place their cystoscope in places other than the bladder. I certainly was. Although as a trainee I wasn't allowed to do it. It seemed like a good idea to use a telescope rather than a big cut. But this was the first documented case in a dog in 1901. But in the 1970s, by this time, and certainly when I'd started training, the gynecologists were doing a lot of diagnostic laparoscopy, looking for endometriosis, ovarian cysts and the like, or to make a diagnosis of pelvic inflammatory disease. And it certainly really did catch on amongst the gynecologists, but gynecologists, being what they are, didn't really share this information with the rest of surgeons, and probably the general surgeons didn't listen to them, and it didn't catch on until this guy, Mouret, in France, did the first laparoscopic cholecystectomy. Now at this point all the general surgeons thought, ooh, our most remunerative operation is being done a different way. Maybe I'll use my private practice if I don't start doing it laparoscopically. So suddenly the general surgeons saw the sense in doing laparoscopy, and maybe my assessment of their response was a little bit cynical, but nonetheless they all started to do it in the late 1980s. And the first nephrectomy was done by Clayman in the United States in 1990, and in Leeds and in Australia in 1993 we were performing the early nephrectomies in children by a transperitoneal route. Now, pediatric laparoscopy has been a little bit behind other specialties, and I know we only have one pediatric endoscopic surgeon in the audience, but nonetheless there has been a delayed uptake by pediatric surgeons of most surgical innovations. Most surgical innovations. And one of the reasons was the size of the instruments compared to the size of the patients. But there have been an advance in the size of instruments, they've reduced in size, the technology has improved, and with this it's been possible to apply the majority of laparoscopic techniques to the child or to the smaller patient, even to the 2 or 3 day old baby. In addition, the awareness of patients has led to increased demand. People want keyhole surgery, and it's up to us to provide it if it's appropriate. And currently in the US, a survey of the surgeons there, and pediatric urologists in particular, show that the majority now perform endoscopic procedures, and certainly the whole of the new generation of trainees is able to do laparoscopy, at least diagnostic laparoscopy. So it's here to stay. The question about this, and I think this is a big debate for us to discuss perhaps later, is laparoscopy a surgical tool or is it a surgical speciality? Now I tell my colleagues that you wouldn't dream of specialising on the basis of whether you use a scalpel or scissors. So I don't think you should specialise on the basis of doing a laparoscopic or an open procedure. Laparoscopy is a surgical tool. If laparoscopically is the best way to do it, we should be doing it that way. We shouldn't make excuses for ourselves. So what are the principles of laparoscopy? You've heard these before, I'm sure, but I don't think you should do anything laparoscopically unless it's as good as an open procedure, because the bottom line is the patient needs a good operation. So don't, to use a common expression, don't make a mess of things just because you have to do it laparoscopically. If you're in a situation where the safest way is to do it open, do it open. No one's going to sue you for that. It's got to be safe. Laparoscopy can be extremely dangerous. No one would dream of doing a laparoscopic heart bypass operation, although I'm sure you could do it. It's got to be safe. There's got to be a low risk. And it's got to be practical and cost effective, because certainly in our National Health Service we have a limited amount of resource available in terms of our operating time, and we have a lot of patients waiting to be operated. If we do a procedure that takes 4 times as long, but has very little discernible benefit, then we're not serving our population of patients very well. So these are the established indications that we currently have in laparoscopic pediatric urology. Impalpable testes, varicocele ligation are very much the domain of the beginner. And these are an important group of patients with which we can learn a technique and the fundamentals of laparoscopic surgery. Nephrectomy is the next level. But most laparoscopic endourologists doing pediatrics are now doing their nephrectomies that way. And I haven't done an open nephrectomy now, apart from for Wilms tumour, for about the last 5 or 6 years. Abdominal diagnosis is another area, although it's small, and that actually particularly is the case when we're looking at intersex conditions and we're trying to diagnose the internal gonad situation. It's a very useful tool. And there's a few extended indications, and things are moving forward all the time that we'll talk about as well. So let's look about the impalpable testes. Now, a single port laparoscopy is what we should all start with. So when you see a patient with an impalpable testis, there's your chance to find out what's going on. And this is the blind ending vas. In an absent testis, about 30% of patients with impalpable testis may have a blind ending vas seen in the abdomen, overlying the iliac vessels, and that's the sign of probably an intra-abdominal torsion in early testicular development. Or you might see an atrophic testicle where the vas, this is on the right side, and the vessels here are atrophic. Unfortunately, I've not got the other side to compare with. This is the internal ring, and they're going through the internal ring, so the inference from here is that there has been a distal problem, maybe an in utero torsion within the inguinal canal leading to impalpability, and this atrophic vas vessels is diagnostic of that. Or you may see in a fat boy, and this may be the case in situations like Prader-Willi or other situations where the child is very fat and chunky and difficult to examine, you may see a normal vas and a normal vessels going through the internal ring, and there may be a small diminutive testicle in a normal position or in an ectopic position. You just can't feel it because the size of the child doesn't lend itself to an examination. Or it may be a truly intra-abdominal testis seen here on the left-hand side with the vas coming from behind the bladder here, the iliac vessels here, the vessels coming down, and this peeping testis with the internal ring just lying inside. Okay, so we can diagnose what's going on, and a single port laparoscopy is all we need to do. So we can take this group of patients. Undescended testis has an incidence of 1 in 100 kids, and impalpability has an incidence in those patients of 1 in 5. So actually we've got 1 in 500 newborn boys that's going to need a laparoscopy. So get hold of that group of patients, and in a decent unit you're giving birth to several thousand babies a year, 10,000 babies a year. Thinking about it, that's a couple of handfuls of patients for you to deal with from the beginning. So this is a good group of patients to do diagnostic laparoscopy. But it's also a good group of patients in which you can move on to the next phase. This is a patient with a blind ending vas here. Looking around on the serous tendon, the serous muscle here, just on the body of the serous, look, there's a dissociated testicular body, a dissociation of the testis from its collecting system. And of course this can't be brought down, so we remove it with a normal testicle on the other side, and you can put in 2 more ports. You can hold the testicle with 1 grasper, you can use an active diathermy in your scissors, and you can remove the testicle with it. And that's a nice little procedure to do, which saves the patient from the risk of cancer, which is probably about 20 times the normal risk of testicular cancer in this patient, as you know. Or you can do, in this intra-abdominal testis here, is the testis, is the vas here, and what we're doing is the vessels coming from above, again on the right side, we're making a little window, and we're just clipping the vessels at the stage 1. Here's an auto suture clip applicator, and we put a couple of clips on here just to identify the vessels for the later stage. And this is the principle of the two-stage Fowler-Stevens orchidopexy. You divide the vessels because they're the short elements. You can't bring them down because the vessels are short. So you divide the vessels, or you clip them and occlude them, and you allow the small vessels running alongside the vas to hypertrophy, and then about 3 to 6 months later you go back and you do the second stage. So here's the same testis. Those are the 2 clips there. So we'll reach in and grab that, and we'll pull it medially. Don't forget this is on the right side, and laterally. And we can see now we're going to divide between those 2 clips. There's the vas running in here. You can just about see it. Little vessels with it. Testis is mobilized medially, and we're just dissecting down. And this is strip of peritoneum. We're just mobilizing. There's little blood vessels in it, and this is going to give us a nice length of tissue. We're holding the testicle up. You can see the vas here, the vessels running alongside it, just dividing these little peritoneal attachments. The next slide's a bit quick, so you've got to catch it. But you can see we put a port down through the scrotum, through the internal ring, and we're just pulling the testicle there, and the testicle is brought into a nice position in the scrotum in 2 steps. There's two stages, 6 months between the 2. And that's a nice result, and that's laparoscopically. Now, there's other ways of doing this. There's other ways of bringing in palpable intra-abdominal testicle down, but they're pretty nasty in terms of the surgical experience for the patient. The Jones technique is a wide laparotomy, where you dissect the vas and the vessels all the way up to the lower pole of the kidney. And you can get them down in 81% of cases, but it's a massive dissection and a big incision, in particular in the abdomen. And it takes a long time for the patient to recover from that, and they end up with a big scar. Microvascular anastomosis is similar. You excise the testis, you find an adjacent blood vessel near the scrotum, and you re-anastomose it to that. Some people are very good at this. Adrian Bianchi in Manchester is excellent at this technique, and these are his results, 84%. But you see, materially, there's not really statistical difference between the results in all of these 3 cases. And in fact, this is a very simple procedure that can be used by the majority of surgeons. And therefore, this is the state of the art, the laparoscopic technique. Varicocele ligation we're going to do later. Here's a patient with a varicocele. We can see now what we're doing is we're mobilizing the testicular vessels. Actually, this is a different patient. Obviously, that's the right side. This is the left side one looking from above. These are the testicular vessels, exactly the same as for the Fowler-Stevens orchidopexy. You mobilize them and clip them. And I don't separate out the artery from the veins. I clip the lot, and it doesn't make any difference. You resolve the problem with the varicocele in over 80% of cases, and there's complications for this as for the open procedure. But you have 3 little port sites. The patient goes home the same day. The open approach, there is a muscle splitting incision above the groin. It's pretty tender and a very different experience for the patient. And if you compare the results, and don't forget our ideal is the results should be at least as good as the open technique. Let's not compromise on that. And you get a hydrocele in about 3 to 9%, depending on the series that you read, with inguinal varicocele ligation, a high ligation, and failure, in other words, continuation of the varicocele in 16%. And this is identical in the series reported for laparoscopic varicocelectomy. So we fulfill the criteria, but we minimize the trauma to the patient. So this must be the way to go. Nephrectomy. Now, I said this is the next level, and there are various indications for nephrectomy. These are the absolute indications for nephrectomy, and any testicle fitting in these categories, I would always remove laparoscopically without any doubt, unless the patient had had previous abdominal surgery. Multicystic dysplastic kidney, poorly functioning kidney for whatever reason. Nephrogenic hypertension, it works really well for this if you've got a unilateral abnormal scarred, poorly functioning kidney, and you remove it. We've shown in a recent paper that is about to be published in the British Journal of Urology that when you take out the kidneys laparoscopically in these patients, it's not the technique of laparoscopy, obviously, but it's very quick to resolve the hypertensive problem, and it's a nice indication for laparoscopic nephrectomy. And sometimes you get patients who are incontinent and they've got an absent kidney and you can't find out what's going on, and you laparoscope them and you find an ectopic kidney which you can remove. I've had 2 patients like this, and you do a diagnostic laparoscopy, you find where the kidney is, and you remove it because of its poor function, and they can be dry. Because the ectopic ureter that drains the kidney no longer has any urine going into it. You remove the kidney, you remove the urine, you remove the wetness. Now, those are the absolute indications, but there are some relative indications as well. And as you do laparoscopic cases, you start off with simple things like multicystic dysplastic kidney, you move to more difficult cases. If you have a waiting list and you work your way through it and you like the technique, then you look to do the more difficult cases and you advance. If a patient's had previous renal surgery, for example, a pyeloplasty, but they've got poor function, this makes it more difficult. There's been scarring, there's been previous dissection around the kidney, but you can, with care, perfectly safely remove the kidney laparoscopically and one's done it. If they've had bad infection, for example with vesicular-ureteric reflux, and even a patient who had a subphrenic abscess in association with pyelonephritis did have a successful laparoscopic nephrectomy. The caveat is that if you have a patient with xanthogranulomatous pyelonephritis, this is the most difficult nephrectomy that we will ever do. Do not try it laparoscopically, but you can make that diagnosis before the operation. Now, malignant disease in children is a no-no. Just because of the nature of the disease, at the moment, I would not advocate compromising the cure of a patient, which is over 90% in Wilms tumour, just because you want to do it laparoscopically. I think that to get the best cure, you need a big hole at the moment. And that's different from the radical nephrectomy you saw this morning. Different indication, different disease, and different prognosis. And trauma, again, because our policy is to treat trauma conservatively in almost every case, then a laparoscope is not going to be a controlled way to explore this kidney. If you want to explore a kidney that's got a hematoma around it, you need a big hole, because you'll need big clamps to stop the bleeding. But if you look now at people's experience, and this is Hamilton's fairly early experience, there may be quite a difference in the operative time, but a significant difference in the post-operative stay. Patients go home earlier. This is children, and that's why the numbers are small in these series. But it was clearly demonstrated, as in with other laparoscopic indications, that this was a much better way of doing things in terms of the patient's experience post-operatively and their recovery. And if you look at the transperitoneal outcome, and this is the way that I first did it, this is the group in Leeds. I worked with Azad Najmani in Leeds in the early 90s, and this was his first 24 patients. Of 24 children, one was converted to open. That's a pretty good rate of conversion. The operation time was about 85 minutes, not bad, and actually comparable to the American time for open surgery, wasn't it, which was 120 minutes. And the hospital stay was 2 days. But that included pre-operative workup the day before the operation, and therefore probably nowadays one would reduce that to 1 day. In fact, more often than not we do. So this is a transperitoneal patient. These are the first 31 patients that I did laparoscopically. I did them all transperitoneally. And this video is just briefly showing division of the lateral attachments of the colon so it can be mobilized medially. This is the left kidney, and the kidney is now being held in a grasper, and this clip applicator is going across the renal artery. Actually, that's probably the renal vein, just completing the dissection of the kidney before it's removed. But in the first 31 patients, the median age of these patients was 5 years of age, 20 nephrectomies, 11 nephroureterectomies. One patient was converted, and this was for bleeding. And the reason I converted was because there was inadequate control of the renal artery, which I divided solely with the harmonic scalpel. I don't do that anymore. I put clips on all of them because it's safer. And this is a nephroureterectomy going right the way down to the lower end of the ureter. We're looking down into the pelvis. The bladder's on our right, and this is the vas is actually in this fold of tissue here. And this is the kidney and the ureter going into the basket. There we are, there's the ureter. And zip it up. Ooh. I love that instrument. Okay. The operation time in these was about 85 minutes. They required analgesia on request by the nurses for about 6 hours, and they stayed 1 day post-operatively. But arguably, I had a new registrar who sent one of my patients home the same day as surgery. So if you compare the trans versus the retroperitoneal, there's various studies that have looked at this, and this is one by Resweiler in the European Journal of Urology, And you can see that the operative time of laparoscopic, whichever approach, is similar, and in his hands greater than open surgery. But there's a dramatic difference between both of these and the post-operative pain relief, and also the hospital stay. Now, this is a very long time to stay in hospital as a child, and actually none of our children, even for major bladder reconstruction, stay longer than 10 days. So I think he was keeping his patients in a long time, but nonetheless a discernible difference there. And the so-called return to normality, difficult to assess, but actually much quicker in the retroperitoneal and the transperitoneal cases. But you can see a similarity between the laparoscopic approaches. Now, if you go retroperitoneally, you go from behind, and you do the dissection with a balloon, and I'll talk about nephrectomy a little bit later, because we're not going to show you the case. But you place a balloon, and we make our own balloon and inflate it with air to create the space for our first port. And these are the results from our series at Great Ormond Street in the Middlesex Hospital. This is 3 or 4 surgeons operating, and there was 102 nephrectomies, of which about half were retroperitoneal and half were trans. My colleagues that started later started with the retroperitoneal approach, so the majority of the transperitoneal patients are mine, but the op time was about equal. There was a bit less pain if you went through the back, but it was less useful for removing the whole of the ureter down to the bladder, as you've seen. So we felt that the indication for transperitoneal was if you wanted to excise a big ureter down to the bladder. But the advantage of the retroperitoneal approach was that you could keep the peritoneum intact. In a renal failure patient requiring 2 kidneys to be removed, they could stay on their peritoneal dialysis, and this wouldn't necessarily affect their renal management in spite of the surgery. And often, if you're going to take kidneys out of a patient on dialysis, there's a lot of issues this could avoid them. I'll show you the video in its completeness later on. Now, another area, so that's nephrectomy, and we'll talk a bit more about nephrectomy with slightly longer videos, is abdominal diagnosis. And that was a patient who had a Wilms tumour. I'll play that again for you. And had intraperitoneal rupture. And we wanted to know whether the intraperitoneal deposits that we could see were actually viable tumour. The tube that you saw actually was the tube from an ordinary laparoscopic instrument, and down it I placed a flexible biopsy forceps as you'd use in a gastroscope. And that worked quite well, although you can get special biopsy forceps. My principle of using the minimal number of instruments was supported by a little bit of improvisation there. If you're looking at patients with intersex, laparoscopy is a very good way of diagnosing the conditions, and this is looking at the pelvis in a patient with intersex and impalpable gonads. And here we can see on one side, on the right-hand side, a streaked gonad, okay, an abnormal streaked gonad, and on the left-hand side, a very unusual-looking gonad. And this is a patient with Turner syndrome who had some malignant change in these gonads and required bilateral oophorectomies. And this is a patient with an X fragment in a karyotype who is at risk of tumour in the gonads, and so these were excised laparoscopically as well as making the diagnosis. You can look at the Müllerian structures if you're worried about an intersex child, you wonder what they've got inside. We're looking down into the rectum is here. This is actually a normal-looking cervix, uterus, and fallopian tubes and an ovary here in a girl. But sometimes you need to make sure, because your ultrasound can't tell you, your various other modalities of scanning can't tell you, you've got to make sure that you can get the diagnosis. And laparoscopy with another port, just so you can manipulate. This is about a 6-month-old baby. Okay, this is quite a big instrument here, but it's the same size as the ones you've been using outside. And this is a baby uterus, which confirms that she was a normal developed female internally. This is an ovarian cyst. Now, in children, ovarian cysts come and go. So if you see one, you wait for 6 weeks and you repeat the scan. But this is a large ovarian cyst which we marsupialized and removed. This is a boy with hyperspadias who's got a large Müllerian remnant, or we call this a prostatic utricle or a utriculus masculinum in the urethra, and we took this out laparoscopically with 3 ports. These are the fallopian tubes, and the dysgenetic gonads that went with this boy were also removed. So we can actually take things out if we need to. Okay, so those are the things that I've been doing for quite a long time, and which are now very established in the armamentarium of a paediatric urologist using a laparoscope. There's a few other extended indications, which are a little bit more difficult, and, if you like, are the next level. Heminephrectomy, pyeloplasty, and ureteric reimplantation. So let's look at those just briefly. Well, this is the classical way in David Thomas's textbook of removing the upper pole. You mobilize the ureter, you find the vessel and divide it, and then you separate between the abnormal upper pole and the normal lower pole. Well, here what we've done exactly the same. We've cauterized around the joint, we've put an endoloop around it, occluding it, and then we just chop that off. Actually, it's quite an effective way of doing it. There's other ways of doing it. You can remove the upper pole with a harmonic scalpel. But obviously, in this situation, if you encounter bleeding, it's much more difficult to deal with. And so I think the endoloop is a slightly more secure thing. But you would choose your patients carefully for this procedure. Here's a pyeloplasty. Now, my current belief is that the best way to do a pyeloplasty is with a muscle-splitting groin incision. But this is my colleague Azad Najmaldin from Leeds doing a pyeloplasty, and you can see you can mobilize the renal pelvis here, just opening it up. There we go. And you can re-anastomose. He actually keeps the ureter attached and re-anastomoses it with a nice wide anastomosis. And his results in these children show, in the 10 children, 2 were converted because this is a very much more difficult procedure with the suturing involved. But he documented success at up to 3 years in 80%. Now that's lower than we'd have with an open pyeloplasty. Open pyeloplasty with a success of about 96%. So this needs a little bit more rationalization, a little bit more care. He got 1 urinoma around it and uses a drain now to avoid that. And it took about 3.5 hours. It takes me about an hour and a half to do a pyeloplasty. Arguably one could do maybe 3 cases in the amount of time it took to do this one. So it's not for everybody, but it is developing, and I think with the robot that you'll see later, this is going to be an established indication for pyeloplasty as well. Now, ureteric implantation can be done in various ways, but this one is done into the bladder. This is the bladder catheter, and these are the ureteric orifices on the right and on the left. And here we can see, just picking up the ureter, there's a suture, and this is dissection of the ureter into the bladder, much the same as you would do with an open reimplantation. Here's the ureter coming into the bladder here. Okay, this is the upper right edge of the trigone, and what we're doing now is to making a tunnel. You can see across to the other side. There we go. You've got to get the angle of your instruments right for this, obviously, because otherwise you can't make the tunnel and just tear the mucosa, and then pull the ureter through. And there's the ureter lying under the mucosa, the contralateral ureter is over here, and you can see you can do a couple of little sutures to secure it. And although technically I don't think this is neat, you can actually physically do a colon reimplantation, and this has been done in 12 children, again in Leeds, for these various indications. Not very long, does it? Just takes an hour and a half to, well, about 3 hours in this case, and 2 of them were converted because of difficulties. Not very long follow-up, but nonetheless, it's possible. So we've got to think carefully about whether our laparoscopic procedure is going to be as good as a conventional procedure. And I think I've shown that in the majority of cases that we currently do, it certainly is. It's got to be safe with a low risk, and in particular in children where the margins are narrower, we've got to think about that very carefully. It's got to be practical and cost effective because we're not treating just one patient in our practice, we're treating a population. And so if we switch to something which takes 3 times as long, the whole group of patients that we treat may be compromised. And so we have to be careful. We have to talk to our healthcare managers about these implications. But we mustn't change the indications. They've got to have the same indications for laparoscopic technique as they would for open. We mustn't do laparoscopy just because it's there and we want to do it. We must do it for the same reasons. Look, robotic surgery is here to stay. And actually, my view is a similar view to many other surgeons, although I don't do robotic surgery. This is a demonstration case. It's very good. It works brilliantly. It takes longer than conventional laparoscopy, and those people that are good at conventional laparoscopy are now telling me that they're not going to abandon it for the robot. The robot takes more time, it costs more money, and in the majority of things that you've seen, it probably doesn't enhance things. Where I think it will help is if we're doing major reconstruction, the construction of an ideal pouch, for example, for bladder augmentation, will be much easier with the robot, and it remains to be seen whether colleagues start to do that and whether that becomes a main indication for it. But people are pushing the field of laparoscopy forward, and with the robot, that's one area where things are advancing. So who knows, in a few years' time, you may all be using them. So, laparoscopy may be a very effective way to do surgical procedures, and it's certainly beneficial to patients in those indications I've shown you. The indications are increasing with the experience and the technology that is available, and I believe, and I put it to you, and obviously being here, you're converts to the thought that it's an essential surgical tool and we must all learn how to do it. Thanks very much.
What is your experience in pediatric in laparoscopic surgery, incision hernia? We know that even 5mm port site also may cause incision hernia in pediatric age group.
Okay, so the question is, how often do we get incisional hernias through the port sites? The answer to that, I think I've had 2 in 6 years, so very few. And the way to avoid it, first of all, the umbilical port, which is where you tend to put the larger trocar. If you're going to use a 10-11mm trocar, I always do an open Aston technique and put a suture around it, normally a 2/0 vicryl, a purse string, that secures the port site around the port and stops the leakage of CO2, but also enables you to close it effectively. And I'll show you that later. So the umbilical one, very rarely. In fact, I would say that it's quite useful to do it that way because in the future we have umbilical hernias, and we always fix those when we do a laparoscopy. So that's a little fringe benefit. The other sites, I've had one in an inguinal site, and that was due to using a 10mm port again. If you use 5mm ports, my experience is with a normal child, it's almost unheard of. But you can, in your closure, just pick up the fascia, just put a little tacking suture across. So it's pretty rare, I think, unless you use the bigger ports. But most of the ports I use are 5mm, so I don't really count on that problem. Yeah.
Thank you, Mr. Peter, for your excellent presentation. I would like to learn your opinion about impalpable testicles. For 2-stage, for instance, procedure. At first stage, at which level you will get the vessels? As far as from the testicle, or is there any difference to clip to close the testicle?
Okay. The question is, how close to the testicles do you ligate the vessels in the Fowler-Stevens orchid effects? Well, let's see what I did, shall we? I mean, here you can see the vessels here and the vas here, and I'm at least 3 centimeters above the testis. You see these vessels here? I want to preserve them. So I'm actually ligating proximal to those. The closer to the testicle you are, the more of the accessory blood supply you're going to compromise. And you want to aim for a strip of peritoneum which is about 2 centimeters wide. So you want to stay at least 2 centimeters above the testicle when you do it. So, just so people here, who's laparoscoped before? Who's doing regular laparoscopy? Anyone here doing laparoscopy in any size patient, not just children? So we've got 1, 2, 3, 4. Okay, put your hands up, come on, don't be shy. So there's 4 people who have done laparoscopy. So how many of you have done doing interventional laparoscopy, and how many are doing just diagnostic? You're doing both. Okay, are you doing diagnostic? Okay. Well, I think it's important to try. The general surgeons have really had an advantage here because they've had They've had patients with non-specific abdominal pain or possible appendicitis. And this is a great group of patients. Maybe they see 4 or 5 of these patients a week, where the laparoscope confirms a diagnosis. Okay, appendicitis is a clinical diagnosis, but actually there's nothing to be lost by doing a laparoscopy before your appendicectomy, is there? And so they have a ready group of patients which they're immediately able to apply laparoscopy to and learn the basic techniques very quickly. And then they're able to take those patients on to the next stage and start to explore the removal of the appendix, and those surgeons now take them all out laparoscopically, don't they? We need to find a similar group of patients, actually, where we can do that. And if you do pediatrics, of course, those are the patients with the impalpable intestines. This is a ready patient group that will supply you with a lot of ability to try your laparoscopic skills and to use them profitably for the patient. Another group is the varicocele patients. Although I think that many varicoceles don't need surgery, a patient that's got symptoms, pain on standing, or has got an atrophic testicle on the ipsilateral side, these are patients where I think they need a surgery, and laparoscopy is a very nice way of doing that because of the post-operative recovery. But when you think about laparoscopy, it's very important to think about your first patient, who you're going to do it on first. And you perhaps need to find a patient who's having a laparotomy, for whom maybe a laparoscopy might be an interesting or a helpful thing to do in the first few moments of the operation. Or a patient in whom you're going to do an open procedure, like, for example, the equivalent of the surgeon's appendicectomy, where you just want to confirm a diagnosis or have a look inside first. And maybe the varicocele is a very good patient to do this in, because you can look, you can confirm the diagnosis endoscopically, you can check the anatomy on the other side, and then when you're ready you can go either to do the inguinal incision and do the high ligation, or you can do it laparoscopically. But you've got to think about your first patient. I think it's a mistake or difficulty if you're going to take on a radical nephrectomy as your first patient. And I think that's the difficulty in urology. You can all think of this being quite tricky. How are you going to get your learning curve for the basic laparoscopic procedures out of the way before you move on to the more advanced things? Now, it sometimes helps to have colleagues that you can work together, and I know that healthcare nowadays often is very demanding on individuals, and it's very difficult to work with colleagues. I know that my 3 colleagues at Great Ormond Street, we very, very rarely get to operate together. When we do, it's always very profitable, because we're able to share ideas and experiences and learn from each other. And if you're open-minded, I think it's a very profitable thing. But if you've got 2 or 3 of you interested in laparoscopy, don't split your patients in 3. Pull them and treat them together. And that way you'll all learn from each other's experiences and get on much more quickly. It depends on the healthcare system. If you're in public healthcare, then there's no real problem with sharing patients. If you're in private healthcare, I know it's a bit more difficult. Your income may be threatened, and I know that this is a real feature in some doctors' existence, just actually surviving financially. But it's worth just putting those things aside and sharing your experience, because it will certainly profit your patients by your greater experience in the long term. Anyone else? Anything? Okay. Yes, go on.
I want to learn about this.
How many patients did you treat first stage for your sequence?
Probably about 30 patients now.
30 patients.
Yeah. If I'll just try and show you something. It won't take a second. I can just find it. So here we go. I have a little sort of my approach to the impalpable testis is just down here. So if you've got an impalpable testis, sorry, it's got a lot of memory in this talk, so it'll take a while to wake up. Okay. So when you can't feel a testicle in a baby, it may be for various reasons. It might be because you've got a very jumpy child, and they're being examined by 4 or 5 other people, amongst them some very earnest and determined surgeons that are determined to feel this testicle, perhaps slightly regardless of the child's reaction. So as soon as he sees another doctor, child screams, you're not going to get very far with a proper clinical examination unless you spend a lot of time coaxing them to allow you, but even then you may not be able to examine them very well. So when you make this diagnosis, the first thing that you do is to examine them under anaesthetic. When they reported the results from Boston of impalpable testes, 30% of their patients, 30% had a transinguinal testis that was diagnosed at laparoscopy. Now I would argue, had they done a careful examination under anaesthetic, they probably wouldn't have done a laparoscopy in most of those patients. And we commonly cancel the laparoscopy because we found the testicle finally with the patient asleep. So in a child, it's very important to examine them under anaesthetic. If you can feel the testicle, then you just go ahead and do a groin exploration and a formal standard open orchidopexy. So that's 30% of the patients that you don't laparoscope. For the rest, you still can't feel it. You get the laparoscope out and do a diagnostic laparoscopy with a single port. If you see the vas and vessels entering the ring, it means one of two things. Either it's a chubby boy and you can't feel the testicle, but it's there after all, and then you can explore the groin and fix it in the scrotum in the same way, or it's not there, and if it's not there, you fix the other side. I think this is very important, that when you're thinking about undescended testicle, you think about both testes. If the testicle is absent for any reason, if the vas and vessels go through the groin and you can't find a testicle on that side, it's torted until proven otherwise, which means that the one on the other side is at risk, greater risk, or at least 1 in 300 risk of being torted, which is the normal population risk. So you have to secure it, so you do an orchidopexy. So the solitary testicle that you confirm is a solitary testicle is safe from torsion. If the testicle is inside the abdomen, then you've got a choice. And this rather depends on what's happening on the other side. If you've got a normal testicle on the other side, and it's an abnormal one, you might just excise it. But because you've got a solitary testicle remaining, you do a contralateral orchidopexy on your solitary testicle so that the chance of torsion is minimized in that solitary testis. If, however, you find the testis, you do a 1 or 2 stage Fowler-Stevens orchidopexy. And I showed you the difference. It's about 60-something% success for a single stage where you divide the vessels and bring it down on that strip of peritoneum in one go. It's nearly 80% success if you do it in 2 stages. So my policy is to do it in 2 stages. I used to try and do a laparoscopic assisted orchidopexy, okay, keeping the vas and vessels intact at the time if I found the testis just inside the inguinal ring, so-called peeping testis. But that's a struggle to do that operation. You deliver the testicle to a high position, and you saw on the video that I got that testicle right down into the scrotum. So I would do a Fowler-Stevens orchidopexy in the majority of intra-abdominal testes, almost without exception. Okay. Any more questions about it? Impalpable testes tend to generate more questions than any information, because it's potentially contentious.
Sorry, one more question. There's a big discussion among pediatric urologists and surgeons for impalpable testicles. Do we have a biopsy or not for those testes? What's your opinion about this?
Okay, well there was an article by a guy called Pike in the British Journal of Urology in '96, which looked at the incidence of testicular cancer in patients with a prior diagnosis of undescended testis. And it found a 25 times increase in risk for an intra-abdominal testis. And one of the interesting findings was that those patients that had a biopsy had a much, much higher incidence of transformation into malignancy than those that didn't. And the message from the paper was taken that the biopsy itself was a risk of malignancy. But this was a false message. The truth of it was that the patients having a biopsy were selected by the surgeon doing the operation, and there's no documentation of this, but this is what I suspect very strongly, because they had a very abnormal looking testicle. And these testicles were biopsied because they looked very abnormal. And my belief is that the form of the testicle, how it looks, its morphology, is very much related to its malignant potential. Okay? The more abnormal it is, the more dysplastic it is, the more chance that it will be malign. So I don't think you can say whether or not a testicle is going to become malignant, but you can make some assessment of it by its morphology. If If it's very high and there's great dissociation between the vas and the body of the testicle, it's much more likely to become malignant than if it's lower and the form of the testicle is much more normal. Now, I don't do a biopsy in these cases. I think if you're trying to preserve testicular tissue, doing a biopsy can compromise the testicle altogether. What I do think you need to do is to bring them down into the scrotum to a place where they can be palpated. And the child should be taught, and the parent should be taught to examine it. And if the testicle changes in its characteristics at all, then they must consult a neurologist. And this is what they need to be told. But I don't think this is a big deal, because I think if you have a daughter nowadays, I would teach her at some stage to examine her breasts and to report any abnormalities that she found. And in the same way, I think we have to teach our sons to examine their testicles and to report any abnormalities too. And actually, it's not hard to persuade a boy to examine his testicles, is it? Yeah.
What is your approach in simple nephrectomy, retroperitoneal or transperitoneal? And also, what can you say in this issue for the beginners of laparoscopy?
Okay. Well, for me it was very straightforward, because when I started to do laparoscopic nephrectomies, the way that we were doing them, everyone was doing them, was transperitoneal. And as you saw, I did my first 30 or so transperitoneally. And so all cases were done the same way. And I still know some surgeons who only operate transperitoneally. And I think that's perfectly acceptable. If you're doing simple nephrectomies in an adult population, and you're also going to be doing radical nephrectomies by the transperitoneal route that you saw earlier on, I think it's perfectly fair that you should do all your nephrectomies that way. I don't have a problem with that. What I found was that when I switched to retroperitoneal nephrectomy, and there's a video on a disc that I think you'll see of the operation that I did here last year, retroperitoneally, was that actually it was easier in many respects. When you come to the kidney from the front, the vessels are in front, the ureter is behind. You need to move the colon off, and I think mobilizing the colon off the front of the kidney, and particularly on the left-hand side by the spleen, can be quite difficult transperitoneally. If you do it retroperitoneally, there's no issue with the spleen. It's in front. You come down on the back of the kidney, you see the ureter, and behind the ureter, or rather should I say in front of the ureter, are the vessels you lifted up, there they are. And you get a very good view. In a child, you have very much a space to work in. In the abdomen, you've probably got 200, 300, 400 cc's of space in a 1-year-old child with your pneumoperitoneum. In the equivalent situation, retroperitoneally, you've probably got 100 cc's of space. And the room for manoeuvre of your instruments, the potential of clashing of the instruments is greater. So I think that in the ideal world, you'd start off transperitoneally and then you'd try it retroperitoneally. Okay? But I think you just got to decide on your approach, and it would be perfectly fair if you wanted to do it retroperitoneally. The thing is, if you do it transperitoneally, you're straight into your space, aren't you? The peritoneum is the ready-made space in which you can work, and that's easy. Retroperitoneally, the difficulty that I found was creating space for the balloon, and that's one more step that you have to do in a retroperitoneal nephrectomy that you don't have to do transperitoneally. So I think that that's something to consider. So do the first few transperitoneally, make it a step, explore the kidney that way, and then try the retroperitoneal route. The best way to do it, actually, is with a surgeon that's already doing it that way, and experience with him. So I think you should pool your cases. If you're in a unit with 5 surgeons, and you decide that you want somebody to do retroperitoneal or laparoscopic nephrectomy, then other guys shouldn't be taking them out open. Okay? They should be giving you their patients, or you should be going to their operating room and operating with them, doing it laparoscopically. That's where you learn together, you increase your experience, and support each other's development. Okay. Now, how are we doing for time? Now, what's the situation with the operating room? Are we...
Operation room is ready, sir.
Is the patient asleep?
Yeah. No, they are waiting for you, sir.
Okay.
They are ready.
Okay.
You can go in whatever you want.
Well, I mean, what I might do, because I haven't shown you the videos, I'll show you the videos of nephrectomy, because I had hoped to demonstrate nephrectomy to you this time, but both of the cases, for one reason or another, were not available to us. So let's just show you those videos so you can get an idea. Okay, we've got 20 minutes to do this?
Yeah.
Is that okay? Okay, well, I've shown you some of these slides already. These are the indications for nephrectomy. And if you have a population of children that you can operate on, you start off with the easy ones. The multicystic dysplastic kidneys are the easy ones. And the reason they're easy, they have very little blood supply. They don't have great big vessels that have to secure them. You can divide them with diathermy. They're very small because they're non-functioning, completely non-functioning kidneys. Poorly functioning kidneys are a different thing. And some surgeons would vary in their indications to take a kidney out. I would say 10% or less function with a normal kidney on the other side, you would consider a nephrectomy. And particularly if there's a dilated ureter, reflux, a history of infections and the like, then a nephrectomy is probably what you're going to do. Other surgeons will take out a kidney with slightly more function, but you'll know your indications for nephrectomy. But these are a little bit more because they've got a bit of a blood supply and they may be inflamed because of previous infections. And so when you first do these, you've got to be selective unless you're going to get disillusioned because it's so difficult. Because from a multicystic to these fully functioning kidneys is quite a big step. Nephrogenic hypertension, you might be taking out a kidney with considerably more function, of course. But generally they don't have a lot of fibrosis around them. And the invisible dysplastic kidney, well, this is really continuing on from an exploratory laparoscopy looking for this ectopic kidney as a cause of incontinence, and you take it out when you find it. But you work through your indications, but start off with multicystic dysplastics. Okay, up to 10% of antenatally diagnosed hydronephrosis might be a dysplastic kidney. And so if you've got access to those patients, you'll see several of them a year. And previously the conservative view was pertained, where even a persistent dilatation or cystic kidney after a year or two of age will be left in. Nowadays, our view is that because you can remove it endoscopically, very simply with a minimal stay in hospital, and afterwards you don't have to follow them up, is that we do a laparoscopic nephrectomy in these patients and then discharge them about 6 months later. So that's our view. And this has given us a large number of patients in which to operate. All of these things, you work onto these things when you get happy and familiar with the more simple ones. I never do a nephrectomy in a patient like this. I mean, looking at this tumour, it's completely impossible to consider that you'd actually attempt to take this out other than by a big open incision. And of course, it's very, very dangerous to do so. And this is a very much exaggerated case, of course, but one of the features of renal tumours in children is that they're very, very large, and they may also be necrotic internally with big pools of blood and necrotic tissue inside them. It's very difficult to handle them with these relatively sharp instruments. So we don't do it. We use our big blunt instruments, our hands to handle them, and we can take them out safely that way. There is more time when you do it laparoscopically, and when you do it, I mean, it's really important to actually give yourself plenty of time. So if you're going to do a laparoscopic nephrectomy, give yourself a whole day. Give yourself a fit patient, a relatively simple case, and plenty of time, so that you maximise your learning, that you can relax about other factors. There's nothing worse with having the theatre administrators coming in and telling you, because you're taking a little bit longer, you're going to have to cancel 4 cases. I mean, that's really very, very stressful. So you've got to give yourself a fairly stress-free environment, hopefully the support of a colleague who's familiar with laparoscopy, and just take your time. And I found in that situation, even the difficult ones actually work out okay. It's when someone's breathing down your neck and telling you to finish because there are 3 more cases to do that things really get bad. So don't do that to yourself. Be quite prepared to take a lot longer than 175 minutes if you need to. As you can see, the outcome is pretty good. Although the op time is great, the hospital stay is really short. And as I said, the way I found this out was when one of my patients got sent home by a new registrar before I come to the ward at the end of the afternoon to review him at the end of the list. Okay, multicystic dysplastic kidney being taken out laparoscopically is probably a day case procedure, or certainly can be. And particularly with the retroperitoneal ruse. Okay, you won't look at that because I've got the full video to come. I'll turn the music off. Okay, so this is the axis for transperitoneal nephrectomy. The patient's on this side, the head's up this end, the feet's down this end, and this is a circumumbilical incision here, and this is the edge of the rectus sheath. In the right outlet, this is anterior superior iliac spine, this is the rib cage, and there's two working ports here. This is the umbilical port, and I've tended to use a larger port for the umbilicus because then I can use the endocatch basket to actually take the kidney out. I always put an open technique for the umbilical port, and these are the accessory ports just going on. You can see I use Stort's reusable ports. I think these are the best, to be honest. You can spend a lot of money on disposables, but I tend to use reusables. I think it's economically and environmentally much better. Here we can see just mobilizing in this left nephrectomy the colon and just retracting immediately, looking for the space where the